We've covered what to eat. Now let's cover everything else the 2026 guidelines recommend. And let's go deeper than most patient education ever does on one topic in particular: exercise, and specifically your muscle. Here's something that most people are never told. Your skeletal muscle is not just for moving your body around. It is one of the most metabolically important organs that you have, arguably as important to your long-term cardiovascular and metabolic health as your liver or your pancreas. Some researchers now call it the organ of longevity. We're going to explain exactly why, what happens when you lose it, how to build and protect it at any age, along with the rest of the lifestyle factors that guidelines address: sleep, stress, smoking, and alcohol. So, why is muscle a metabolic organ? When most people think of muscle, they think of strength, appearance, or athletic performance. In cardiovascular and metabolic medicine, muscle means something else entirely. It is your body's largest site of glucose disposal and a major regulator of your entire lipid and insulin system. Here is what skeletal muscle actually does metabolically. Skeletal muscle accounts for 70 to 80% of insulin stimulated glucose uptake in your entire body. When you eat a meal containing carbohydrates, the majority of that glucose doesn't go to your brain or your fat tissue first. It goes into your muscles, where it's either used immediately for energy or it is stored as glycogen for later use. This single fact is why muscle mass and muscle quality are so directly tied to insulin sensitivity and therefore to triglycerides, HDL, and the entire atherogenic lipid picture that we discussed in the triglycerides video. Muscle tissue also plays a direct role in fat metabolism. Mitochondria, which are the energy producing structures inside our cells, are where fatty acids get oxidized for fuel. More muscle mass and more metabolically healthy or fit the muscle specifically is means a greater capacity to burn fat as fuel rather than allowing it to accumulate in the liver, in the pancreas, and in the bloodstream as triglycerides. During exercise, contracting muscle releases signaling molecules called myokines. These are hormone-like proteins that travel through the bloodstream and have effects on the liver, on fat tissue, blood vessels, and even the brain. Some myokines directly reduce inflammation, and others improve insulin sensitivity throughout the body, not just in the muscle that release them. This is part of the explanation why exercise has cardiovascular benefits that go well beyond simply burning calories. And this is why some researchers and clinicians have started calling skeletal muscle the organ of longevity. Multiple large cohort studies have found that low muscle mass and low muscle strength, independent of body weight or BMI, predict higher all-cause mortality, higher cardiovascular mortality, faster functional decline with age. Grip strength alone, a simple proxy for overall muscle health, has been shown in large population studies to be one of the strongest predictors of survival in older adults, a more powerful predictor in some analyses than blood pressure. Now, sarcopenia, what is that? The silent loss of muscle. Sarcopenia is the medical term for the progressive, age-related loss of muscle mass, strength, and function. The name comes from Greek. Sarx means flesh, penia means loss. Here's the part almost nobody tells patients. Muscle loss begins far earlier than most people think. Without intervention, adults begin losing muscle mass at a rate of about 3 to 8% per decade, starting in their 30s. And this rate accelerates significantly after the age of 60. By age 80, an inactive person may have lost 30 to 40% of the muscle mass they had in their 20s and 30s. Why does this matter for cholesterol and cardiovascular health specifically? As muscle mass declines, the body's capacity for insulin-stimulated glucose disposal declines right along with it. This is one of the underappreciated reasons insulin resistance becomes so common with aging. It is not simply about getting older, it is substantially about losing the metabolically active tissue that handles glucose and fat. Less muscle means less of that 70 to 80% glucose disposal capacity we just discussed, which means more glucose and more fatty acids left around circulating, which, as we covered in the triglycerides and insulin resistance video, drives up VLDL production, raises triglycerides, lowers HDL, and promotes a small, dense LDL particles. Sarcopenia is also frequently accompanied by an increase in fat mass, especially that visceral fat, which is a combination that researchers call sarcopenic obesity. This combination is metabolically worse than either low muscle mass or excess fat alone because you get the harmful inflammatory and insulin resistance promoting effects of visceral fat without the protective glucose disposing benefit of adequate muscle to offset it. A 2022 meta-analysis pooling data from over 50,000 older adults found that sarcopenia was associated with a significantly higher risk of cardiovascular disease and cardiovascular mortality, independent of traditional risk factors like LDL and blood pressure. Other studies have linked low muscle mass to higher rates of metabolic syndrome, type 2 diabetes, and frailty. The encouraging news is that sarcopenia is one of the most preventable and even reversible age-related conditions that we know of. Unlike many aspects of aging, muscle responds to training at virtually any age. Studies of resistance training in adults in their 80s and 90s have shown meaningful increases in muscle mass and strength within just 8 to 12 weeks. Now, exercise guidance, starting safely and building up. Let's talk about that. The 2026 guidelines, consistent with decades of cardiovascular evidence, recommend at least 150 minutes per week of moderate intensity aerobic activity plus resistance training at least twice a week. But the guideline number is a destination. It is not a starting point. And how you get there matters enormously, especially if you haven't exercised in a while. So, if you haven't exercised in a while, you need to start low and build slowly. This is one of the most important pieces of guidance in this entire video, and it is frequently skipped over in cholesterol education. If you have been sedentary, do not jump straight into an intense program. This isn't just about comfort, it's about safety and long-term adherence. Here's why starting gradually matters biologically. Deconditioned muscles, tendons, and joints need time to adapt. Cardiovascular fitness, which is your heart's ability to handle increased demand, also needs a gradual ramp up, especially if you have any underlying risk factors like high blood pressure, high cholesterol, or if you're over 50 and haven't had a recent checkup. A sensible starting approach looks like this. Week 1 to 2. Start with a 10-minute walk once or twice a day. That sounds almost trivially small, and that's intentional. The goal is to build the habit and let your body begin adapting without triggering excessive soreness, injury, or the kind of overwhelming fatigue that causes most people to quit in the first week. Weeks 3 to 4, you can extend it to 20 or 15 or 20-minute walks, gradually picking up the pace to a quote-unquote brisk level, meaning you can still talk, but you would struggle to sing. Week 5 to 8, you build toward 30 minutes, 4 to 5 days a week. This is roughly when you'll be approaching the 150-minute weekly target. Now, once you're consistent, begin layering in variety, a mix of walking, cycling if you can, swimming, or dancing at home, and begin adding light resistance exercises as well. What are signs that you're progressing too fast? Well, new joint pain that doesn't resolve within a day or two, excessive fatigue that lingers into the next day, resting heart rate that stays elevated, or dread or dislike for the activity. Any of these are signs to back off on the intensity or duration and rebuild more gradually. A simple intensity guide, the talk test. So during moderate intensity exercise, you should be able to hold a conversation but not sing. If you're so out of breath that you can't speak in short sentences, you're working at a vigorous intensity, which is fine once you're conditioned, but not where a beginner should be starting. If you have known heart disease, uncontrolled blood pressure, or if you haven't exercised in years and you are over 40, a conversation with your doctor before starting and possibly a supervised cardiac rehab or exercise stress test is reasonable and a recommended step. It is not an overreaction. Resistance training, it is not negotiable at any age. Given everything we just discussed about muscle as a metabolic organ and the reality of sarcopenia, resistance training deserves to be treated as seriously as aerobic exercise, not as an optional add-on. The 2026 guidelines recommend resistance training at least 2 days a week, working all major muscle groups. So the legs, the hips, the back, the chest, the abdomen, the shoulders, the arms. You do not need a gym or heavy weights to start. Body weight exercises like squats, wall push-ups, sit to stands from a chair, resistance bands, or light dumbbells are all effective starting points, especially for beginners or older adults. Now, for someone who hasn't done resistance training before, starting with body weight movements like chair squats, modified push-ups against a wall or a counter, seated rows with a resistance band, 1 or 2 sets of 8 to 12 repetitions twice a week is a completely reasonable and effective starting point. Progression comes from gradually increasing repetitions and then adding resistance, then increasing sets, not from immediately lifting heavy weight. Balance training, essential for older adults. This is a category that standard cholesterol-focused lifestyle advice almost never mentions, but it belongs here because falls are one of the leading causes of disability, hospitalization, and loss of independence in older adults. And falls become substantially more likely as muscle strength, coordination, and balance decline together with age and inactivity. The 2026 guidelines, in line with broader geriatric and cardiovascular prevention recommendations, specifically call out balance training as part of a comprehensive physical activity plan for older adults. Generally recommended 2 to 3 times a week for adults over 65 or for younger adults with any condition affecting balance or stability. Examples of balance exercises. Single leg stance. So standing on one foot for 10 to 30 seconds, holding onto a chair or a counter for support initially, and then progressing to no support. And alternate legs. The heel to toe walking, which is called tandem walking, means you're walking in a straight line, placing the heel of one foot directly in front of the toes of the other like a walking tightrope. It's excellent for training the same balance reflexes used to prevent falls. Tai Chi, a slow-flowing martial arts-based practice that has an exceptionally strong evidence base for fall prevention in older adults. There are multiple randomized trials that show Tai Chi practice reduces fall by about 20% or more, while also providing mild aerobic benefit and stress reduction. Sit to stand repetitions, rising from a seated chair position to standing without using your hands, repeated 8 to 10 times. This simultaneously trains your leg strength and the functional balance and coordination needed for everyday movement. Clock reach or 4 square step. So standing and reaching one foot in different directions, like the numbers on a clock face, while maintaining balance on the other leg, is used in many physical therapy and fall prevention programs. It's something you can try at home. Balanced training combined with resistance training has been shown in clinical trials to reduce fall risk in older adults by 30 to 40%, which has obvious direct benefits but also an indirect cardiovascular benefit. Falls and the resulting injuries are one of the most common reasons older adults become sedentary, deconditioned, and subsequently develop worsening metabolic and cardiovascular profiles. Preventing the fall protects the whole system. What the evidence shows about exercise and your lipid panel. Let's recap and expand on this. As covered in our lifestyle video, aerobic exercise lowers triglycerides and raises HDL most prominently, with a more modest direct effect on LDL, roughly 5 to 8%. But when we add resistance training and consider the muscle as organ framework, the benefits compound. Improved insulin resistance from both more muscle mass and more metabolically active or mitochondria-rich muscle. Better glucose disposal capacity, reducing the chronic hyperinsulinemia that drives VLDL overproduction. Reduce visceral fat, which independently improves your entire lipid profile. Lower systemic inflammation through the myokine release we just talked about. Preserved or improved muscle mass, protecting against the sarcopenia-driven metabolic decline that we just talked about. This is why the 2026 guidelines and the broader cardiology and exercise physiology literature no longer treat aerobic exercise alone as sufficient. Both aerobic and resistance training are now considered essential, complementary components of the cardiovascular and metabolic risk reduction. Now let's talk about sleep. Sleep was touched on briefly in our triglycerides discussion, but it deserves a greater treatment here as a core lifestyle pillar in its own right. The 2026 guidelines aligned with the American Heart Association's Life's Essential 8 framework for cardiovascular health formally include sleep duration and quality as a modifiable risk factor, not an afterthought. The target 7 to 9 hours of quality sleep a night for most adults. Poor sleep, whether due to insufficient duration, fragmented sleep, or sleep disorders like obstructive sleep apnea, drives up cortisol, worsens insulin sensitivity, increases appetite for high-calorie and high-carbohydrate foods, and raises your blood pressure. Each of these independently worsens your cardiovascular risk profile, and together they compound. Practical sleep hygiene steps with evidence behind them. Let's go. Keep a consistent sleep and wake time, even on weekends. Circadian regularity itself improves metabolic markers independent of total sleep duration. Limit screen exposure for 30 to 60 minutes before bed. It is believed that blue light suppresses melatonin release. Keep the bedroom cool. Keep it dark and quiet. Core body temperature drop is part of the natural sleep onset process. Avoid caffeine within 6 hours of bedtime and alcohol within 3 hours. Avoid caffeine within 6 hours of bedtime and alcohol within 3 hours. Both fragment your sleep, even if they don't prevent falling asleep. If you snore loudly, gasp during your sleep, or wake up unrefreshed despite adequate hours in bed, ask your doctor about screening for obstructive sleep apnea. This is common, it is underdiagnosed, and directly tied to worse triglycerides, worse blood pressure, and cardiovascular outcomes. What about stress management? Chronic psychological stress activates the hypothalamic pituitary adrenal axis, and that leads to sustained elevation of cortisol. Chronically elevated cortisol promotes the visceral fat accumulation, it worsens insulin resistance, it raises your blood pressure, and it has been linked in some studies to accelerated progression of atherosclerosis or plaque, independent of traditional risk factors. The 2026 guidelines acknowledge psychosocial stress, depression, and social isolation as risk-enhancing factors for cardiovascular disease, a meaningful elevation from how old guidelines treated this topic, so we need to pay attention. What are evidence-based approaches to stress reduction? Well, they include regular physical exercise, which is itself one of the most effective stress reduction tools that are available. The muscle-released myokines that we just discussed earlier also have a mood and stress modulating effect. Mindfulness-based stress reduction programs, which have randomized trial evidence for reducing blood pressure and improving the markers of cardiovascular risk. Adequate sleep, since sleep deprivation itself amplifies stress reactivity. Social connection. Strong social ties have repeatedly been shown in large cohort studies to be associated with lower cardiovascular risk, while social isolation and loneliness are associated with risk increases comparable in magnitude to some traditional risk factors. Professional support. Therapy and counseling for chronic stress, anxiety, and depression are legitimate medical interventions that have downstream cardiovascular benefit and not unrelated soft concerns. What about smoking cessation? Let's revisit this with full context. So, smoking cessation remains one of the single highest impact actions for cardiovascular risk reduction of anything covered in this entire series, arguably higher impact than any individual dietary change. Smoking damages the inner lining of the blood vessels. It's called the endothelium. It promotes the oxidation of LDL particles, which makes them far more atherogenic. It lowers HDL, increases blood clotting tendency, and accelerates atherosclerotic plaque formation through direct toxic and inflammatory effects of combustion byproducts. The encouraging evidence on quitting is cardiovascular risk begins dropping within days of quitting. Within 1 year, excess risk of coronary heart disease drops by half compared to continuing to smoke. Within 5 to 15 years, the risk approaches that of somebody who never smoked, depending on the smoking history. There is no point at which quitting fails to provide benefit. Even people who have smoked for decades see meaningful risk reduction upon quitting. If you've tried to quit before and it didn't work, that is not a sign that you can't quit. Most successful quitters required multiple attempts. Nicotine replacement therapy, prescription medications like varenicline, bupropion, and behavioral counseling each roughly double quit success rates, and combining the approaches increases your success chances further. What about alcohol? Let's revisit that as well. As discussed in the triglycerides video, alcohol is a potent driver of triglyceride elevation through hepatic de novo lipogenesis and impaired VLDL clearance. Beyond lipids, alcohol also raises your blood pressure, contributes to weight gain, can trigger atrial fibrillation, which is an irregular heart rhythm, and in excess directly damages heart muscle. It's called alcoholic cardiomyopathy. The 2026 guidelines recommend limiting alcohol to no more than 1 drink a day for women and 2 drinks a day for men, and emphasize that less is better. There's no level of alcohol consumption proven to provide net cardiovascular benefit once rigorously studied with modern epidemiological method, contrary to older beliefs about moderate drinking and heart health that have not held up under more careful scientific scrutiny using methods that correct for prior confounding. For anyone with elevated triglycerides, specifically reducing alcohol intake or eliminating it entirely is one of the fastest, most effective single changes available, often producing measurable improvement within 2 to 4 weeks. Now, let's put the complete lifestyle picture together. Across this video and the 2 before it, the full lifestyle picture that the 2026 guidelines and supporting evidence point to looks like this. Diet, Mediterranean or DASH style eating pattern, emphasizing vegetables, whole grains, legumes, fish, nuts, and olive oil, limiting red and processed meat, added sugar, and refined carbs. Aerobic exercise, building gradually to at least 150 minutes per week of moderate intensity activity, starting low and slow if you've been inactive. Resistance training, at least 2 days a week, training all major muscle groups to build and preserve muscle as a metabolic organ and to protect against sarcopenia. Balance training 2 to 3 times a week for adults who are over 65 or anyone with balance concerns to reduce fall risk and preserve independence and activity capacity. Sleep 7 to 9 hours nightly with consistent timing and good sleep hygiene. Screening for sleep apnea if symptoms are present. Stress management through physical activity, mindfulness practice, social connection, and professional support when needed. Smoking, complete cessation using all available support tools regardless of how long you have smoked. Alcohol limited to 1 drink a day for women, 2 drinks a day for men, with less being better, and minimal to none if you have elevated triglycerides. Weight management, a 5 to 10% reduction in body weight where applicable, achieved through the combination of all of what we just talked about rather than extreme or unsustainable measures. None of these factors work in isolation. They are deeply interconnected. Muscle mass affects insulin sensitivity, which affects triglycerides, which affects your whole entire lipid panel. Sleep affects stress hormones, which affect both blood pressure and appetite, which affects weight, which affects insulin resistance as well. This is why the guidelines frame lifestyle as a comprehensive, integrated approach rather than a checklist of disconnected tips. Now, if there is one message to take from this video, it is this. Your muscles are not just for moving. They are one of your most important tools for protecting your metabolic and cardiovascular health for the rest of your life. And they respond to training at any age, even into your 80s and 90s. Combined with adequate sleep, stress management, smoking cessation, and moderate alcohol intake, building and maintaining muscle through both aerobic and resistance exercise is just as foundational to your cholesterol and your cardiovascular risk as anything that you eat. Start where you are. If it means a 10-minute walk today and 2 body weight squats tomorrow, that is a legitimate evidence-supported beginning, not something to be embarrassed about. The goal is sustainable, gradual progress that you build into the rest of your life.